Welcome to the holiday edition of the Kent Northwest Kidney Center monthly in-service. Today I want to compare and contrast the two dialysis modalities that are available to our patients, peritoneal dialysis and hemodialysis. They both feature the same underlying mechanism, which is diffusion, but otherwise the techniques are profoundly different. The lifestyle is different. Even clinical outcomes may be different between the two modalities. As usual, there are four objectives. We'll review the functions of the kidney, review the hemodialysis procedure, followed by the peritoneal dialysis procedure, and then we'll compare the clinical outcomes of the two forms of dialysis, specifically focusing on mortality data. So what do the kidneys do? Well, as you all know, kidneys remove waste products from the blood. They also remove fluid. They regulate the acidity of the blood, or the pH. They help control blood pressure, and they produce hormones, activated vitamin D, as well as erythropoietin, which stimulates red blood cell production. If you don't have normal kidney function, then your body accumulates waste products, and this can lead to the clinical syndrome called uremia, which often features nausea, vomiting, weight loss, and fatigue. You can retain fluid, resulting in edema, as shown in the picture here. If you retain fluid in your legs, you may also retain fluid inside your blood vessels, which will raise the pressure in the blood vessels and cause hypertension. And if you don't produce erythropoietin, you will develop anemia. And if you don't make vitamin D, you will have unhealthy, unhappy bones. So what does dialysis do? Well, dialysis tries to replace the function of the kidney, so it cleans the blood, it removes fluid, it regulates the pH of the blood, helps control blood pressure, and during the procedure, of course, we administer hormones like activated vitamin D as well as erythropoietin, or Mircera in our case. So what is dialysis? Well, in the global picture, it's mechanical treatment of kidney failure, but scientifically, it involves the diffusion of particles, so the movement of particles from an area of high concentration to low concentration across a semi-permeable membrane. And that's what's shown here in this diagram. You see two compartments of fluid separated by a semi-permeable membrane with a high concentration of red dots on one side, and over time, the two concentrations equilibrate by the process of diffusion. Let's begin with a discussion of the hemodialysis procedure. As you all know very well, during dialysis, blood is removed from the body of a patient, typically through a dialysis fistula, but sometimes through a dialysis graft or a catheter. Passes through a tube to a dialyzer, and the dialyzer is the artificial kidney. We'll talk about it in a second, but basically it is a large semi-permeable membrane that separates blood from dialysate, and dialysate we'll go over in a second, but basically it's similar to normal saline plus other electrolytes, magnesium, calcium, glucose. Okay, so the dialyzer contains thousands of porous capillary-like fibers carrying blood within the dialyzer shell, and it collectively serves as the dialyzer membrane across which blood and dialysate allow for diffusion. Blood flows through the insides of the fibers, which are thousands of tiny hollow tubes the size of hairs, and dialysate flows outside of the fibers. Dialysate is an electrolyte solution, similar to plasma, but can be individualized for a patient. It contains 6 electrolytes: sodium, potassium, calcium, magnesium, chloride, and bicarbonate of varying concentrations. For example, in this diagram, the sodium concentration is 140. At the Northwest Kidney Center, we use 135 milliequivalents per deciliter. All of these can be tailored or individualized if needed, but usually there's a standard dialysate solution, and the only thing that we really change on a regular basis is the potassium concentration. Typically it's 2 to 3 millimoles per liter, although it can be higher or lower depending on the patient's needs. So the procedure of dialysis brings together blood and dialysate separated only by a semi-permeable membrane, and this allows for diffusion to occur. Again, diffusion is the movement of particles from an area of high concentration to low concentration. And by the process of diffusion, hemodialysis is able to remove waste products from the blood. So waste products from the blood diffuse into the dialysate and then go down the drain. This movement, however, can be bidirectional. So for example, if the calcium concentration is higher in the dialysate than it is in the blood, then calcium will infuse into the blood. Now, dialysis involves more than just diffusion. It also allows for the procedure of ultrafiltration. Ultrafiltration is a removal of fluid from the patient. It occurs when pressure is applied to the capillaries of the dialyzer, forcing fluid with the same electric composition as plasma across the semipermeable membrane to the dialysate side of the membrane and down the drain. Ultrafiltration can be done simultaneous to diffusion, or it can be done separately. So if we want to just remove fluid from a dialysis patient, we would arrange for an ultrafiltration session, or a so-called SUF run. This stands for sequential ultrafiltration rather than simultaneous ultrafiltration and hemodialysis. Hemodialysis is typically done in a dialysis center on a thrice weekly schedule, either a Monday, Wednesday, Friday schedule or a Tuesday, Thursday, Saturday, or Sunday schedule. So why do in-center dialysis patients dialyze 3 days per week? I mean, kidneys work 7 days a week, so why would we only do dialysis 3 days a week? Well, it's not for physiologic reasons. When dialysis was pioneered in the 1960s in Seattle, the nephrologists wanted to dialyze as many people as possible, and so they split up the patients into two groups, a Monday, Wednesday, Friday group and a Tuesday, Thursday, Saturday group. And then everyone took Sunday off. And as dialysis technology spread across the world, the thrice weekly model spread with it. So wherever you go in the world, typically is 3 times weekly. But the schedule has problems. For example, the chance of a dialysis patient dying from sudden cardiac death is twice as high after the long weekend. That is, on a Monday for a Monday, Wednesday, Friday patient, or on a Tuesday for a Tuesday, Thursday, Saturday schedule. And of course, kidneys work 24/7, and so more frequent dialysis has theoretical advantages. Enter peritoneal dialysis, which is a procedure done on a daily basis and in theory offers a more physiologic schedule of removing waste products and fluid from our dialysis patients. Peritoneal dialysis is similar to hemodialysis in that it involves diffusion and ultrafiltration, but the procedure is vastly different and there is no external dialyzer. Instead, we use our own internal peritoneal membrane as the semipermeable membrane for dialysis. So how is peritoneal dialysis done? It begins with the placement of a thin flexible tube into the peritoneal cavity that protrudes from one of the lower quadrants of the abdominal wall, maybe about 6 inches, and then dialysate is infused into the peritoneal cavity of the abdomen where it comes into contact with the peritoneal membrane. So the peritoneal membrane is a thin lining of the abdominal cavity that wraps around the internal organs. The term peritoneum is derived from the Greek word peritonean, which means to stretch around. So it stretches around our organs. The total surface area of the peritoneal membrane is about 1 to 2 meters squared, and it contains thousands of capillaries. The normal function is to minimize friction of your internal organs, facilitate motion. It carries blood vessels and nerves to the organs. It's also part of your immune system, so if any bacteria escape from the intestines, it has inflammatory cells there that can kill them. It also serves as the dialyzer membrane in peritoneal dialysis that separates dialysate from the blood in the capillaries. When we instill dialysate into the peritoneal cavity, fluids and dissolved substances are exchanged across this semipermeable membrane between the blood and the peritoneal space by the process of diffusion. Fluid removal is accomplished with peritoneal dialysis by the addition of dextrose, which is a large sugar molecule, into the dialysate. And dextrose serves as an osmotic agent which draws fluid from the capillaries into the peritoneal cavity. And when the dialysate is drained from the peritoneal cavity, it removes the additional fluid that is drawn or sequestered from the vascular space by ultrafiltration. There are two ways peritoneal dialysis can be performed. One is called continuous ambulatory peritoneal dialysis, or CAPD, and the other one is continuous cycler peritoneal dialysis, or CCPD. CAPD, or continuous ambulatory peritoneal dialysis, is done first by hanging a bag of dialysate on an IV pole and allowing gravity to drain the fluid into the peritoneal cavity. The fluid remains in the cavity typically for 2 to 4 hours, during which time diffusion occurs between the blood and the dialysate. Dialysate containing waste products is then drained out at the end of this so-called manual exchange. CAPD does not require a machine. The process uses gravity to fill and empty the abdomen, so it's really good. For example, if the power goes out, you can still do your dialysis at home. A typical prescription for CAPD involves 3 or 4 of these so-called manual exchanges during the day and one long overnight dwell, typically lasting 8 to 10 hours as the patient sleeps. Typical manual exchange takes about 30 minutes, so if a patient does 4 a day, can spend approximately 2 hours per day, 7 days a week doing their peritoneal dialysis. The typical fill volume is 2 liters, sometimes 2.5 or even 3 liters, and it's done 7 days per week. CCPD, or continuous cycler peritoneal dialysis, is done using a machine called a cycler. It's most often done at night while the patient sleeps. Patients connect their peritoneal dialysis catheter to a tube that is in turn connected to a large bag of dialysate, and then presses a button on the cycler and goes to bed. And while the patient sleeps, the machine gently pumps fluid into the peritoneal cavity, where it typically dwells for about 90 minutes, during which time diffusion and ultrafiltration occur. The cycler then drains the peritoneal cavity, which completes the first cycle, and then it pumps more fluid back into the peritoneal cavity, and the process repeats. A typical prescription for CCPD would include 3 or 4 exchanges at night over a 9-hour period, and after the last cycle, the cavity is again filled with dialysate and remains present during the day until the afternoon, when the patient performs a midday manual exchange. So it drains out the fluid and uses gravity to drain more fluid into the peritoneal cavity. Most patients do CCPD rather than CAPD because this saves time. I mean, you do 3 of your 4 daily exchanges at night while you sleep, and so it really frees you up to do other things, for example, go to school or go to work. So, as you can see, both hemodialysis and peritoneal dialysis involve diffusion. Both of them require a dialyzer of some sort, either an external dialyzer or the semi-permeable peritoneal membrane. But they are vastly different procedures. Let's now compare some of the differences. There are several practical advantages of peritoneal dialysis. It's less expensive. There's no need for a dialysis nurse. It's done at home, so you don't need a dialysis facility. There's greater mobility of peritoneal dialysis relative to hemodialysis, so it's really easy to travel. You have more regular control of volume and waste products. You're removing some every day rather than every 2 to 3 days. Peritoneal dialysis is very efficient at removing potassium. So about 80% of peritoneal dialysis patients actually need potassium supplements, and this allows for a more liberal diet. Peritoneal dialysis also allows for a more flexible schedule. So most people do it at night. It's easier to go to school or work. There's no need for vascular access. Patients love the fact that they don't have to get poked with large needles 3 times a week. And on a practical note, it engages the patient. So patients have to be very involved in their own therapy, and so most peritoneal dialysis patients really understand the process well and are actively involved in the procedure. Despite the advantages of peritoneal dialysis, peritoneal dialysis is only done in a minority of patients. About 11% of dialysis patients globally do peritoneal dialysis. In the United States, it's about 12%. So why is this? Why is peritoneal dialysis done less often? For starters, there are some absolute contraindications to peritoneal dialysis. For starters, patient disinterest is common. A lot of people don't want to have a tube in their belly. A lot of people don't want to do their own dialysis at home. So if they're not interested, they're clearly not a candidate for PD. You have to have a suitable home environment for peritoneal dialysis. So you can't be homeless. You need to have enough space at home to accommodate peritoneal dialysis and its supplies. Most skilled nursing facilities do not allow for peritoneal dialysis. So that rules out nursing home patients. A lot of dialysis patients also have a dysfunctional peritoneal membrane, so it doesn't allow for adequate diffusion or ultrafiltration. This can occur because of an anatomic variant or can occur as a consequence of prolonged peritoneal dialysis. We think that exposure to high concentrate dextrose can incite some low-grade inflammatory changes in the peritoneal membrane, which over time sort of burn it out for peritoneal dialysis. And if you've had a lot of episodes of peritonitis, this can of course scar your peritoneal membrane, so it doesn't work anymore. There's also a long list of relative contraindications to peritoneal dialysis. These include bowel pathology, for example, inflammatory bowel disease or recurrent diverticulitis or recurrent Clostridium difficile colitis. Abdominal wall hernias are common, and they can enlarge in secondary to peritoneal dialysis because you're putting fluid in there which puts pressure on the abdominal wall, and that can make a hernia worse. If you have cirrhosis of the liver and ascites, patients can lose a lot of that ascites, very rapidly become volume depleted, and not do well with peritoneal dialysis. Uncontrolled diabetes can be made worse with peritoneal dialysis because, again, we are putting dextrose into their abdomen, and they can absorb that dextrose. Also, if patients have really high serum glucose values, then they won't be able to remove fluid well because, again, there's the concentration gradient between the dextrose in the dialysate and the blood, which drives the removal of fluid into the peritoneal cavity. Patients have to have the cognitive ability to do peritoneal dialysis. Some patients have a sort of permeable diaphragm, and the dialysate can traverse the diaphragm, resulting in a pleural effusion, which can cause shortness of breath. Some patients just have pain during the dialysate procedure. Sometimes the catheter can irritate nerves in the peritoneal membrane, resulting in a lot of discomfort during the procedure. And finally, loss of urine output occurs in most dialysis patients over time, and peritoneal dialysis is more dependent than hemodialysis on something called residual renal function. Basically, if you're always making some urine, that assists a lot in volume control as well as clearance of the blood, even if it's only 5%. But if you do 5%, 7 days a week, that's a lot of added clearance. And if you don't have that residual renal function, then you have to do more peritoneal dialysis, and sometimes that extra work, doing 5 or 6 exchanges per day, can burn patients out. There are other reasons why hemodialysis predominates. For example, most nephrologists feel more comfortable with hemodialysis than they do peritoneal dialysis. Nephrology training in this country is heavily focused on hemodialysis. Acute dialysis, so someone has acute kidney injury and they need dialysis, it's exclusively managed with hemodialysis based on studies that suggest better clinical outcomes with hemodialysis in this setting. And finally, it's easier for nephrologists to see their patients at the dialysis unit where they are a captive audience rather than wait for the peritoneal dialysis patients to come to their clinic. Follow-up is oftentimes unpredictable. I've had PD patients that I've followed in the outpatient setting that I haven't seen for a year because they don't come to our clinic. They're doing fine, but they just don't come to the clinic, and it's sometimes hard to manage them. Sometimes patients don't receive proper education before dialysis starts, and if they're not told about peritoneal dialysis, then they won't choose it. Also, if they're not properly educated about PD, it might sound creepy to them. If you say, oh man, we're going to put a tube in your belly and you're going to flush fluid in there and it's going to sit there and you're going to drain it out, it's easy to turn a patient off. So you have to explain it carefully, otherwise that might be a deterrent. And finally, if patients just come to the hospital because they're sick and it turns out they have renal failure and they never saw a nephrologist before starting dialysis, then they will get started on hemodialysis. And once they're on hemodialysis, sometimes it's hard for them to consider switching to a different form of dialysis. Finally, patient fatigue is a factor that causes a lot of patients to switch from peritoneal dialysis to hemodialysis just because of the work involved with peritoneal dialysis, particularly as their residual renal function declines and they need to do more PD for clearance or ultrafiltration. So it's a lot of work for them to do your dialysis at home. It is less work to go to a dialysis unit, close your eyes, hold out your arm, and have a nurse do everything for you. Additionally, there are some advantages to hemodialysis. Almost any patient can do it. Dialysis nurse evaluates the patient 3 times per week, so they're receiving constant medical attention from a trained professional. Once they're in the dialysis unit, they're a captive audience, so they're easy to be seen by the nephrologist. And there is at least the potential for more predictable volume control, particularly in patients whose peritoneal membranes are not properly suited for allowing for ultrafiltration, or diabetics whose sugars are often high and maybe don't remove fluid very well with the peritoneal dialysis procedure. Ever since the inception of dialysis, nephrologists have wondered, do patients do better with one form of dialysis over the other? That is, are clinical outcomes superior with one form of dialysis? A large number of studies have tried to answer this question, but they've had difficulty for at least 3 reasons. One, there is a potential for bias. So patients who choose one dialysis modality over the other may have certain clinical or social characteristics that influence the outcomes. So for example, someone who chooses PD may be more likely to live independently at a home that is large enough to accommodate the medical equipment and supplies. And in most cases, they are not residents of a nursing home, and they are certainly not homeless. Or another example, a nephrologist might steer their patient towards one modality or the other, and might suggest that an independent working patient who's a little bit healthier might do better with peritoneal dialysis. Second, there are no randomized controlled trials available to adjust for potential confounders that may influence the outcome. So the best data we have are observational studies, which we'll go over momentarily, and offer conflicting results. And finally, mortality associated with peritoneal dialysis may be improving. So some of the older studies which suggested no benefit may no longer be relevant. So for example, in the 2016 US RDS report, so the United States Renal Dialysis System report, the 5-year survival for peritoneal dialysis increased 51% compared with only 41% among hemodialysis patients. The potential for selection bias was highlighted in the 2002 CHOICE study. The objective of the study was to compare baseline comorbidities of patients who chose PD versus hemodialysis. So they compared baseline characteristics of 279 incident PD patients and 759 incident hemodialysis patients. And then what they found was that people who chose PD had significantly fewer comorbidities. So the conclusion of the study was that healthier patients are more likely to choose peritoneal dialysis, and this, of course, can affect long-term outcomes. One way to control for selection bias is a randomized controlled trial, and this would answer the question about long-term survival associated with 2 forms of modality, but it's unlikely to be ever done. So it was tried in 2003 in the Netherlands. Basically, it was a randomized controlled trial of incident dialysis patients who were randomized to either hemodialysis or peritoneal dialysis. And out of 738 patients, only 38 agreed to randomization. So 700 patients said, no, you're not going to tell me what kind of dialysis I'm going to do. And as a consequence, the sample size was too small, so they couldn't actually answer the question. But the study did show that we'll probably never be able to get patients to do a large randomized controlled trial to actually answer the question. Let's review some of the observational studies that suggest mortality benefit associated with peritoneal dialysis. This is a retrospective study of 12,000 Canadian dialysis patients who were followed for up to 5 years, and they found that PD was associated with significantly lower mortality rates compared to hemodialysis after adjusting for prognostic factors. A USRDS report in 2009 showed that there was a survival benefit of PD for the first 3 years of dialysis treatment, but by 5 years, mortality was the same for PD and hemodialysis patients. And a USRDS report in 2018 showed that people who started peritoneal dialysis in 2011 had a 5-year survival rate of 52% compared to only 42% for those on hemodialysis. Some observational studies have shown no difference in mortality between people who do peritoneal dialysis or hemodialysis. This is a retrospective study in Canada of 822 incident dialysis patients between 1993 and 1994, followed for 2 years, and they found no difference in survival between the two groups. Another study in Lombardy, Italy, followed patients for 4 years and found no difference in survival rate or the development of cardiovascular complications between the two modalities. Some observational studies have suggested that mortality is worse with peritoneal dialysis. This is a Korean study looking at 32,000 incident dialysis patients, and they took 7,000 PD patients and matched them to 7,000 hemodialysis patients who had similar propensity scores or baseline comorbidities, and they found that the mortality rate with PD was higher, significantly higher than in the hemodialysis group. This was a U.S. study, retrospective, looked at 107,000 incident dialysis patients. 33% had heart failure, and they found that if you were on peritoneal dialysis and had heart failure, mortality was much worse than if you were on hemodialysis. And finally, in the CHOICE study in 2005, a U.S. study basically looked at 1,000 patients starting dialysis, found no difference in survival between PD and hemodialysis for the first year, but thereafter, patients who stayed on peritoneal dialysis had worse mortality compared to those who were on hemodialysis. And then there are a whole bunch of observational studies which basically show mixed results and are very confusing. So for example, this is a study done in Michigan that found that if you have end-stage renal disease secondary to hypertension, there was no difference in mortality for patients who did PD versus hemodialysis. But if you had diabetes or glomerulonephritis, your mortality was lower with peritoneal dialysis. These three studies, Held, Vonesh, and Winehandle, all showed that there was no difference in mortality between the two modalities if you were a non-diabetic, but showed increased mortality if you were diabetic. And finally, McDonald showed in this study of 27,000 patients in Australia and New Zealand that mortality was lower at 90 days with peritoneal dialysis, but by 12 months it was higher with peritoneal dialysis. So in summary, the literature is really unclear regarding mortality benefit associated with either modality. Some studies suggest early mortality benefit associated with PD, but no difference in the long run. Other studies suggest higher mortality rates associated with PD use among diabetic patients. So if you spend a lot of time reviewing this literature, it will hurt your head. Brace yourself for the quiz. What percentage of dialysis patients in the U.S. do peritoneal dialysis? That's right, only about 12%. Question number 2, what is the process by which fluid is removed with dialysis? Excellent. Ultrafiltration. Again, in hemodialysis, pressure is applied to the capillary tubes, which forces fluid across the semipermeable membrane into the dialysate side. Name 3 potential advantages of peritoneal dialysis. Very good. Less expensive, it's done at home, so you don't need a dialysis facility. Easier to travel, more regular control of volume and waste products removal. More liberal diet, can eat more fruit, more flexible schedule, and you don't need to be poked in the arm, and it actively involves the patient. Next question, which form of peritoneal dialysis uses a machine called a cycler at night? Excellent. CCPD, or continuous cycler peritoneal dialysis. So most PD patients do this because it saves them time during the day. And the final question, true or false? Randomized controlled trials suggest an early mortality benefit associated with peritoneal dialysis. And the answer is false. Just remember, all the data that we have comparing the two dialysis modalities is observational and confusing. This concludes the Kent in-service for the month of December 2021. Thank you for your attention. Merry Christmas, Happy Hanukkah, Happy Holidays to you all. This is Andy Brokenborough signing out. See you next year.